Awesome. Welcome, everybody. It's good to see you. Um, this is an exciting July month of Men's National Community Health Worker Alliance. It's great to see past presenters like Ray Hernandez, who was our last month's presenter here present. I'll introduce you to our presenter today, and just want to mention that if anybody has a topic that they would feel confident on or want or know somebody that they want to bring on to these to share their expertise and knowledge that applies to men's health, please let us know. We're very collaborative. We will work with you to create presentations and all that good stuff. Um, but welcome. My name is Mike Young. I'm the president of this alliance, and where we center the voices of health, men, and leadership of men who serve our communities. And our alliance brings together men from all walks of life committed to health equity, peer leadership, and community transformation, empowering men as community health workers to lead with purpose and transform community health nationwide. All right. So this month, we're talking about something that gets overlooked, the importance of prostate health. So we're honored to have Jerry Thomas with us today. Jerry is a public health leader with extensive expertise in improving care for men with prostate cancer. He currently works with NYU Langone and
Lingo.
Manhattan VA, and is a co-author on key publications on prostate screening and shared decision making. Anything else you'd like to mention about yourself, Jerry? Welcome.
Um, I guess you covered most of it. Yes, I worked on a few publications. Prior to this, I was working in the nonprofit sector down in Tampa, and I've been lucky to be part of Dr. Joseph Ravenel and Daniel Makarov's team in prostate cancer study over the last almost 7 years or so. So,
Awesome. Yeah. And I want to mention it's kind of awesome that name he just said, Joe Ravenel. He has a TED talk where he talks about uh, a barber shop and a pastor, a preacher, and how maybe not the barber shop, but the preacher, he became like a prostate screening like mentor connector for the community. It was this amazing TED talk, and it was basically really talking about men being CHWs, and I use it all the time. I share that video all the time, and I've even shared it in the beginnings of these meetings. So when he said that he works with the guy that made that TED talk, I was like, that's awesome. I guess it just makes sense. All these worlds are going to collide. Um, but let's get a sense of who's in the room. If you can, we're going to go one by one. Introduce yourself, unmute. I'll call you out. Say your name, where you're from, a little bit about yourself, how long you've been a CHW, but finish this sentence in the chat, or finish this sentence. One thing I've learned about working with men and health is, I'll put that prompt in the chat. So in addition to introducing yourself, answer or finish this sentence. One thing I've learned about working with men and health is. Let's go with Terry Jowers.
Oh, hi, I'm Terry. I am the executive director of the South Carolina Community Health Worker and the godmother of Mantua. Um, one thing I've learned about working with men's health is um, we got a lot of work to do, right? We got a lot of work to do. And the way it's been done for so long is probably wrong. And we just really need to rethink it, right? So, yeah. All right. Ray.
Oh, okay. Hi, Ray Hernandez. I work at the University of Arkansas Medical Science um, Institute for Community Health Innovation. We just changed our name, so I'm still trying to roll it off my tongue there. And I'm a community health worker. My primary function here is to do fatherhood fire programs, parenting, 24/7 parenting programs, and so on. And I've done that for close to 3 years now. I guess the one thing I've learned not only through this job, but other places where I've worked where I was able to be in a role of healthcare for men, is that men have the firm belief that ignorance is bliss when it comes to their health. And if they don't know what they don't know, they don't think it'll hurt them. Uh, and coming from serving 20 years in Marine Corps, it 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 was very much considered weakness to even have to go to the infirmary or to the dispensary, as we call it back then, uh, because we were supposed to be the providers, the muscle force and the workforce and so on. And my heritage is Hispanic, so our machismo is very much based in um, projecting that sort of stoic uh, inability to be hurt by anything. And unfortunately, it that's what kills us far too often is our desire to be seen as impermeable makes us actually very permeable.
Thanks, Ray. Absolutely. That's on point. Yes. Ignorance is bliss. That's not, that sucks. All right. I'll pick, Jerry.
Hey, hello everyone. Jerry Crenshaw. Hail from Nashville, Tennessee,
Nice.
and my background is health information technology. And over the last 5 years, I've worked specifically developing a platform for community health workers. So we're hoping to get our first project launched here in the next couple of months. I'm going to put a link in the chat there to our website
Nice.
for those who are interested. And the one thing I've learned about working with men and health is kind of what the team here has just identified. But one of the things I want to help with is helping to get more men involved as community health workers. So that's, double more awareness in terms of just health in general, but also adding value to the community and raise that awareness within the community as well as for the individuals.
Well, that's exciting. And I mean, we should definitely have a session where we talk about your work, right? I mean, if it's this useful platform, people need to know about it. So
Absolutely. And just a little bit more on that, Mike, is that, a lot of the grant opportunities are requiring that the community health worker document the work that they do. We know that that's a challenge in a lot of different settings. So that's one of the things the platform will help with. So almost like if you're a certified community health worker, you're a free agent, go out there and do your thing, improve the health in your community, but bring visibility to the work you do, and hopefully at some point start to get billed for those services. So we're on that path anyway.
awesome. Very cool. All right, let's hand it over to Ada.
Hello, everyone. Let's see if I can get this on with my screen. Hello, everyone. How are you? I
Good.
am just excited to be here today. My name is Miss Ada Webb. I am a certified CHW, also a county coordinator with UAB, Community Outreach and Engagement. One thing I've learned about working with men in health, I like to use a lot of analogies. One of the one I've used lately is the car. Your car oil needs to be changed, change your oil. Your brakes a little squeaky, check on your brakes. And I use that for them and their body parts when we're talking out in community, when we're trying to get our men screened for any parts of cancer, whether it be prostate, colorectal. We want to just make sure we get them more involved. One of the things that I'm working on right now, we have prostate screenings here at the health department on Saturday. So I partnered with one of my organizations I work with. So the first 10 men that come in the door, they will receive a fishing rod and some fishing gear. I got them. And I got a senior citizen group that's going to do some hamburgers and hot dogs. But that in itself, you see how you guys got excited? That's how the men in the community want to be excited, because we want to make them feel that they're important too, and they are important. Their health is very important. We do a lot for breast cancer awareness, but that was just one of the things that kind of popped in my head this year. Why not work with this organization? And they're tied with Bass Pro Shop, and a lot of guys love to go fishing. So that was my trick this year.
Amazing.
So glad to be on this call. I'm learning more things from you guys, Mike.
Awesome. And we love when there's women present, because I mean, this is a great session for us men to like find and be like, wow, other people feel this way, for the men to connect and be vulnerable. But for women, they get to hear a completely like very open perspective and experience from us. Like it's so valuable. So please tell other women that this Men's National Community Health Worker Alliance it's for everyone and everyone benefits, you know. So thank you for being here. Love to see it. Martin.
Hey, hello. My name is Martin Rivarola. I'm here in Santa Rosa, California,
Nice.
and I got interested in how can I support the goals of the Men's Alliance, community health workers, much like Jerry. I think there's a huge potential for not just men's health, but human being health by having more men becoming CHWs. My heart out to all the women that are the majority of CHW, CHR's promotoras. They're doing incredible things, and in my 20-some year career, I've been mesmerized by their work. But I also think that men, there's room for more men CHWs, and that will also be to the benefit of the whole community of all of us. I recently, my last job was we were awarded CDC CCR 2109 grant here in Sonoma County, and I managed that grant that ended the end of last year. And that grant was to help build the CHW workforce here locally. And I am happy to be here and happy to contribute to the group in any way I can.
Love to see another Californian. I'm from California too, so that's awesome. I'm from Southern California. I've been to a few of the Visión y Compromiso conferences. I went last year. It was awesome. So yeah, good to see you. Welcome. Thank you for being here. Let's see here. Dr. Shanor Huff. Are you there?
Hello. Hello.
Hello.
How y'all doing? How y'all doing?
Great. How are you?
All right. I don't know what we're doing. Are we doing
So
introductions?
quick introductions, but if you can end it with finish this sentence. One thing I've learned about working with men in health is.
Oh, okay. Well, first, let me get that out of the way before I forget anything. The one thing I learned is that we do have a true union, because there's so less of us working in the healthcare field. We have a true union, a true bond. That's one thing I can say.
Definitely.
Okay, and quick introduction. My name is Dr. Shanor Huff. I'm based out of Riverdale, Georgia, and I heard about this through the grapevine, and I'm happy to be here today.
Excellent. We appreciate you being here. Please tell other people.
I sure will.
Kelvin. Kelvin, I saw you were driving. Are you able to unmute and introduce yourself? If you can, it's okay. We see you.
Yeah.
All right.
Hi, I'm Kelvin Gatson, the male involvement coordinator with the South Carolina Office of Rural Health Family Solutions.
Awesome.
We're located here in Orangeburg, South Carolina. I run a fatherhood for 5 counties in rural areas. And one thing I learned about men and men's health I learned that if we talk about it, the more we talk about it, the more we'll pay attention to it. You know what I mean? It's like a football game or anything. You know what I mean? When the conversation get going, it get going. So when we talk about it, it make a lot of more people just emphasize on it. But if we be quiet about it, it's not gonna be done. Nobody gonna say it. We talk about everything else. We talk about the NBA, NFL, the ladies basketball game. We talk about everything but our health. But once we start talking about our health, and we just need to bring that up more in rooms and spaces, making men aware of our health, and we'll make it. We do good with it. When we do it, we do great with it. So let's just keep the conversation going.
Awesome. Thanks for being here. We got to talk about it, and that's what we're here for. The last three are part of my core leadership team here in South Carolina. They do awesome work through CHW, the Association of South Carolina, and some consultation work. Vernon, Daryl, and Rebecca. But if you guys want to say one thing you learned about working with men in health, Vernon?
Just piggyback. Hello, everyone. Just piggybacking off what Kelvin was saying. One of the biggest things is dispelling the myth that we're the ones supposed to fall on the sword and die young, protect the family, do everything else. I think it's all right to live a little while too. And that includes what it takes to do it. Like the young lady Miss Ada was saying about the oil change, getting that tuned up, so we can get another 100,000 miles out of these temples. So but that's one of the things to kind of learn, is dispelling that myth, because a lot of times we're supposed to be we don't deserve things, the simple things that, as long as everybody else is okay, we supposed to be okay. Well, we want to be okay, enjoy it, the fruits of our labor as well. So I'm gonna put it in park right there, Mike.
Awesome. Daryl.
Yeah, basically agree with everyone's saying. The biggest thing with I've learned with working with men is when men do talk to men, we do listen to one another. And the more like Kelvin was saying, we bring up the conversation. And then I think even to piggyback off of Vernon, a lot of times we're so busy taking care of everybody, but just having a conversation with men, well, hey, if you ain't here, you can't take care of nobody. Just being very direct with them. So let's make sure that we take care of ourselves so we can continue to take care of everyone else. And just having those conversations with men and then understanding how we are wired and how we communicate, I think is real good. And then continuing to grow, the knowledge of CHW for men. Because there's a lot of men already doing it. They just don't know there's an organization that something called community health worker. And so just getting more men involved. And I'll stop right there.
Absolutely. Very awesome. Rebecca.
Hey everyone, I'm Rebecca. Probably the biggest thing I've learned about working in men's health is that you got to talk about it, and it's got to be men talking about it. So I've learned that I got to use the good analogies and the tough words sometimes to teach men about how to teach other men about it, and just be persistent about it and explain why it's so important.
Yeah. And if anybody's interested in joining the core leadership team of this organization, we're definitely open to it. Send us an email or tell us in the chat. We'll send you information. We'll just do a nomination form and all that good stuff. We can definitely go in many directions and develop things alongside you in your projects. And before I hand it off to Jerry, one thing I've learned about men's health is you gotta make it cool. You know what I mean? Gotta make it not weird. And like once you make it, chill and relaxed, then it's like, okay, yeah, I feel all right talking about it. So I feel like this crew right here kind of does that. Like we're here to make all of this cool. So
So
ain't nobody cooler than Jerry Thomas with the NYU Langone and the Manhattan BA. I love handing it over to you. So yeah, Terry, were you gonna say something?
Well, I was just, Mike, you said what I say all the time is we have to get so comfortable in our own skin talking about very uncomfortable things, right?
Yeah.
And if we're comfortable, if we're chill about it, whoever's listening is going to feel much more comfortable. So we create those safe spaces. And Vernon, that's exactly what y'all do, right? By talking about it. Kelvin, y'all talk about it. Y'all make it safe for other guys to talk about it. So, God bless you.
Great modeling. Absolutely. We got to set the example. So here's a topic we all need to know more about. So thank you, Terry, for being here, and take it away.
All right. Let me see. Are
What do
you
you want to
guys
tell us?
seeing?
Do you want to tell us one thing you've learned about working with men's health before you kick it off? How about that?
Sure, I could do that. So let's see. One thing that I learned about working with men and health is, um, I guess piggybacking off what Ray said is the whole machismo thing that we will try to push it off and hold off on it. Like I'm guilty of it myself, um, of saying, "Hey, I could do this, I could take care of this," and then eventually I'll get around to it. But try to get that message out, including in my old life, to make sure that I stay on top of it and promote it to people that actually look after their health, do the preventive work. So try to deal with it before it becomes a major issue. So,
Definitely.
yeah.
Awesome.
Let me jump into it. I'll start sharing my slides. Um, are you guys seeing my slides? Just to double check. Okay,
Yes.
perfect. So the project was a randomized trial of a community health worker-led decision coaching to promote shared decision making for prostate cancer screening among Black male patients and their providers. So as we go into these uncomfortable topics, like I believe Terry said, let's talk about the most comfortable topic, which is prostate cancer. So, um, to jump right into it, this project was led by the brilliant principal investigators and architects of our project, which was Dr. Daniel Makarov and Dr. Joseph Ravenel. Dr. Makarov, he's a board certified urologist and a fellowship trained health services researcher. He's an associate professor and director of surgical research at NYU Grossman School of Medicine with the Department of Urology and Population Health, as well as a PI at the VA New York Harbor Center of Innovation, as well as multiple health services research studies focused on the patterns of care in prostate cancer imaging, as well as implementing interventions to improve guideline concordance. He's also an advocate for increased shared decision making between providers and patients, especially in regards to prostate cancer screening, and has produced a white paper in regards to this with the AUA, American Urology Association. Dr. Joe Ravenel, Mike already introduced briefly. He's an associate
Rock
dean for,
star.
huh? Yeah.
He's a rock star.
Yep, I was gonna say he's a rock star everywhere. Even I'm in awe of him when we work together, and I work with them almost like on a weekly weekly basis. So he's the associate dean for professional development at NYU Grossman School of Medicine, as well as an associate professor of population health and medicine. He's a clinical hypertension specialist with strong record in community-based strategies and programs and interventions to reduce racial disparities, focused on the treatment of hypertension and improving cancer screening among Black men in New York City. Mike already gave the intro about his TED Talk. It's a great discussion for you guys to see and listen to about utilizing barbershops to address hypertension. As well as I believe Ted also has a talk in regards to the prostate cancer study, which was the pilot for this project. So now that I set the bar high talking about Joe with his TED Talk, let's lower that expectations down a little bit for me. As you guys know, I'm the project manager at NYU Lego and Health in the VA New York Harbor. But on this slide, the real reason, or the real people I want to talk about, is the real stars of this invention, which is our CHWs. Mr. David Brown and as Mr. Loxley Bowen. The project wouldn't have been possible without them. They integrated well within the community, the patients, as well as within the clinic, interacting with doctors, nurses, staff, everyone up and down. You name it, they talked to them or they knew them. And that's an important part of the CHW work is being able to integrate that on the community side as well as working on the healthcare side too. So quick overview of what we're gonna discuss is just the background for the project as well as the aims of the project. Take a little break to go over the decision aid values clarification for it, and then go over some of the data for our study and some of the challenges we had, as well as share some prelim results. If at any point during this presentation you guys have any questions, just stop me, interrupt me, raise your hand. No, I'm not going to be sensitive to it. So please, I encourage it. More questions, the merrier.
Is it possible to go to full screen mode?
Oh, sorry.
Like,
It's
okay.
I put it in presentation mode. Are you guys not seeing in
We see like the previous, you know, the slide and then the next slide, and if there were notes and that kind of thing.
Oh, that is okay. Let me share the other screen then to see if that works then. Sorry. Because I put it in a presentation mode, but for some reason how about now? Do you guys see
Yes, there you go.
only that one?
Right.
Okay, perfect.
Thank you.
Yeah, the cursive double screens. So um so to provide a quick background, prostate cancer is the most common non-cutaneous cancer among US men, only behind skin cancer. So about 1 in 8 men will be diagnosed with prostate cancer during their lifetime. Estimates from the ACS show about close to 314,000 new cases will be diagnosed in 2025. In regards to cancer death, prostate cancer is the second leading cause of cancer death among men in the US, with a little bit under 36,000 men, about 1 in 44 men dying from prostate cancer. But most men diagnosed with prostate cancer will not die from it. In fact, right now there's about 3.5 million people living with prostate cancer at this time. So there are some uncertainties about the risks and benefits of prostate cancer screening. Many prostate cancers, they're likely to they grow slowly, so they're not likely to cause any harm. While some, they can grow fast and spread to other parts of the body and potentially cause death and other symptoms prior to that. The PSA-based prostate cancer screening is a preference-sensitive decision. I'm going to go into that a little bit more in a future slide of why that is important. Some of the risk factors. Some of the risk factors include age is your strongest risk factor. The chances go up quickly after age 50. And it's rare to get prostate cancer below age 40. The other factor is family history, whereas if you have a father or a brother that had prostate cancer, you're more likely at risk for it, especially also if they had it, but if they got it before age 65. Race is also a factor. Unsure as to a reason why, but it is more common in African American men and Caribbean men with African American descent than other races. In regards to prostate cancer screening and testing, there's 2 avenues currently for screening purposes, which is a PSA test, which is a blood test of a prostate specific antigen. High levels, as a caution, I just want to say that high levels don't always mean that you have prostate cancer. It is a screening test just to see the risk, but you could have a high PSA test, but it could be because you're having infections. You have BPH, which is a benign prostatic hypertrophy, which is just an increase in the size of your prostate gland, which happens to all men as we get older. The second prostate cancer screening test is a rectal exam. which a doctor puts a gloved, lubricated finger in your rectum to feel the prostate gland for size, shape, and texture. I could probably see a lot of the men just shaking their head, being like, "Nope, right now." Um, as an aside, this is part of increasing the knowledge in regards to PSA testing, because some patients don't know that that's an option. They only know about the rectal exam, and they don't want to do that. Like one of the quotes we had from one of our patients that or participants that studied that was part of the study. He said, "I don't want anybody going back up there. I ain't doing that." Um, but this is a blood test. Sure, I'll consider it. So part of it is, increasing the knowledge for that and understanding men. I mean, we're not comfortable talking about health. We're not comfortable with that. And part of the process for this project was having that discussion and prepping them for that conversation with their doctor. And also in regards to a rectal exam, it's not as good as a PSA test, but at the same time, it might find cancers in some men that have low PSA levels. So it might be like an early stage cancer. Um, you have to conduct a biopsy after if, based on your PSA test or rectal exam, if it's suspicious for it, they'll consider a biopsy, which has its own set of side effects and downstream effects after. So, like I discussed about I wanted to come back to a preference sensitive decision. This is why it's important. In 2012, the U.S. Preventive Services Task Force actually recommended against prostate cancer screening. So it wasn't a consideration for high risk subgroups such as Black men or people that had a high risk of cancer. But in 2018, they actually revised it and made it a grade C recommendation, saying that you need to make an informed decision-making approach to PSA screening, aka shared decision-making with your provider. So men have to be informed of and understand the benefits and risks of screening, and you encourage them to make a personal decision. So now, before I jump into the next slide, so how many people, I guess primarily for the men, have had this screening discussion with their provider? You guys can put yourself on mute. Don't jump all into it. So,
We heard all about Daryl's at our
okay.
conference year before last, and it was a room wrecker. It was just people loved his stories.
Uh, Daryl, I'm not sure if you want to share again, or if not, completely understandable. Don't want to put anybody on the spot.
Yeah.
Um,
Just a short version, it was traumatic because I didn't know what I was getting into. And I've known my doctor 20 years, and when I hit my right around my upper 30s and 40s, she started talking about it. And all of a sudden, I'm in there just getting a regular yearly checkup. Then she told me to kind of drop my pants, and I'm like, for what? And next thing you know, she's putting this glove on and this gel, and then all of a sudden she kind of assaulted me, and I'm like, hold up, and it kind of made a little tear come out my eyes. I'm like, what is going on? And then I actually couldn't even look at her afterwards. I kind of had to just look down, and I'm like, man. And then I think the following year she was getting ready to do it again, but I knew it was coming, so I was like, oh, hey, stop right here. And she says, well, you can get a colonoscopy, and I said, wait a minute, they'll be in there a little bit longer. So I kind of gave her, I had to give consent that time, and I still felt bad, But then recently, went to the Sumter Fair and got the deliverance with the blood. They said they'll take your blood and find out the same thing. I'm like, what? You can have my blood, hey? And that to me was it's been the best. I did, matter of fact, 2 years in a row. Just did it earlier last month, and that is the way to go. I'd rather you take my blood than to take it the other way because it was kind of traumatic.
Yep. Yep. I'm definitely gonna say that was I, got into my 40s, had the same experience. I mean, I mentioned that, I'm worried about all these stuff going forward. And he's like, okay, and it just part of my physical, and I'm like, oh, I guess we're doing this. So here we go. Here we go.
Man, I love that.
Um, so, but like, does anybody else want to share any of their stories? If not, I'll move on to the next slide. Um,
Dr. Huff. I haven't got a chance to go in and do the colonoscopy. I'll be doing it soon, so I'm kind of like you all scared. But I did took the what they said, the blood sample or whatever. Everything was good with that. But because of I guess you call the words pollens or whatever, they actually a lot of my mom have them, so she has to go get her cleared out. And I think my brother when he did it, which he was not happy at all. He did the colonoscopy. They found some pollens on as well. So I know I'm gonna have to do it soon. So I'm not ready, but I have to do it soon.
yeah, and that's and like Daryl like touched on that too, and Dr. Huff touched on it too, is also like part of our education process was we had to differentiate between colon cancer and prostate cancer with a lot of the patients that we were because we were at a federally qualified health center like an FQHC, and a lot of the patients don't know that difference. They're like, oh, I did my colon cancer test. I should be good in that, but ignoring the prostate at the same time because they had that thought that, hey, I did this one, so I'm good, like just all around. Um, but I will say, going in regards to prostate cancer screening, you guys and myself are not alone. Um, if you had a shared decision-making conversation, it is rare during that one. For instance, this is part of Dr. Makarov's AUA white paper on shared decision-making. 70% of clinicians actually prefer the style of communication of a shared decision-making. But only 10% of the clinicians actually used it correctly and actually had a shared decision-making conversation with their patients. Patients, 50% of them said that they actually discussed the benefits of PSA, whereas only 15% discussed the uncertainties of PSA, and the downstream complications, and reasons why they wouldn't want to get tested for it. And then, during our baseline analysis, most of the conversations were one-sided because we were able to record some of the appointments prior to the start. For instance, one quote, just as part of it was, hey, since I'm doing your blood work anyway, I'm going to put in an order to check your PSA. And just the patient responded yes, and that was the whole extent of their screening conversation. So it's a very often very one-sided conversation. So to counteract that, we wanted to implement shared decision-making and community health workers. I touched briefly on shared decision-making, which is an approach where providers and patients discuss the evidence-based options and the patients are supported to make an informed decision. Decision coaching, it's an accepted paradigm to improve patient knowledge and incorporate patient values and goals into treatment decisions. I'm not sure who discussed it prior during the introduction. Like it's well understood using promotores in hypertension as well as other preventive care medicines. And CHWs are ideal coaches. They're known for educating the community, building relationships, and gaining respect within the communities. And we're trying to incorporate them more into the healthcare system to be an extension of the healthcare system to provide that peer-to-peer training. So the objectives for our project was one, to evaluate the efficacy of incorporating a CHW decision coaching program to facilitate shared decision making for PSA screening. Also to test whether it improves the provider experience when counseling these Black men considering PSA screening. In regards to what we encompassed was like decision quality, the patient knowledge in regards to prostate cancer, the decision-making process, as well as the patient-provider communication and their PSA utilization. In regards to the PSA utilization, our goal wasn't to increase or decrease PSA screening, but to have the patients make an informed choice with their provider that aligns with their values. And then also obviously determine the cost of the program because that's important for future implementation, sustainability, and dissemination nationwide and at other clinics. And then we did qualitative interviews assessing their experience with the program from the patients to providers as well as the administrators, focusing on the behaviors and norms around PSA screening and how feasible and acceptable they felt. Jerry, I saw you raised hand. Please just go ahead and jump in. So-
Yeah. How did you go about, I know you had the two lead doctors there, but how did you go about recruiting community providers to participate in the program and getting them
so
aligned with the community health worker?
Okay, so in regards to the local providers, so we have affiliations with federal qualified health centers in New York City and Brooklyn, and then we were able to have a discussion with one of the providers and make them like a local clinical champion for us. So they enroll themselves, they would enroll or discuss it with the other providers, and encourage them to participate in the study as well with us. But it was a lot of going back and forth. We did presentations at their department meetings, like their monthly department meetings to recruit the providers as they came on board. We met with some of these providers one-on-one to get them on board because as you guys probably know, with the FQHC, sometimes there's a lot of turnover. So when a new provider comes in, we have to schedule an appointment with them just so we could see their patients as well, and give them, get their approval to join and participate in the study. So,
Also, Jerry, since the CHWs were working under a provider supervision, were you guys able to bill for any of their services, or was this all grant funded as far as the community health workers go?
the project was entirely grant funded from the NIMHD, National Institute of Minority Health and Disparities, under the NIH. So, yeah,
Thank you.
no problem. Yep, and I saw Ray's comment about also in regards to the prostate exam and the blood tests. Yep, and that statement's very, very accurate in the chat. So, all right. Let me see on to our next slide. Here is who we enrolled, or our target population was Black men age 40 to 69 who are attending the FQHC for just a routine primary care appointment. They couldn't have had prostate cancer before or any symptoms related to prostate cancer, such as blood in the urine, lower back pain, because sometimes that would be considered diagnostic testing instead of actual screening testing. And we want to recruit the providers who cared for the patients that fit this inclusion criteria. So in regards to the whole methods for our project, briefly mentioned, we targeted 144 patients, which was adjusted after COVID because our project started right before COVID hit. We'd essentially sent the American Cancer Society decision aid to all patients, whether they were in control or intervention, prior to their appointment. If they were in the control group, they would meet with the community health worker and discuss Life Simple 7, which is like physical activity, healthy diet, managing weight, stopping smoking, and managing blood pressure or blood sugar, and managing cholesterol. And if they participated in an intervention, they would meet with our CHW. They'd go over a whole decision coaching session, which includes like a structured review of the decision aid, focusing on prostate cancer knowledge, values, and their clarification, as well as a role-playing exercise to help them improve their decision making, as well as be able to communicate with their physician or nurse practitioner at their appointment. The CHWs did attend the appointment as well to provide help to the patients during their appointment if they needed, as well as take notes and share notes that they collected during the decision coaching session. I do want to, I guess, take a break, and let's hear what everybody thinks about this. This is the end of the decision aid that I'll share a link at the end, which focuses on what's important to you. Some reasons why you might want to get screened, some reasons why you won't. You guys can put yourself on mute just to get, I guess, like a consensus or an enter in the chat. Hey, will you have peace of mind when you know the test results?
This is Dr. Hub. Will I have a piece of mind? Yes, I think I will. Once I do this, cause like once again, I guess I don't know which one I'm going for. I think the colon, I sort of do the colon exam, so or whatever it's called. Even the prostates, I'm gonna try to do all of it at one time if possible, just to get it over with. Because like I said, if it's early detection, from my understanding, it's the best way to go. So I just want to even be on the. I just want to be there for even for prevention. If I don't have anything, I hope I'm good and everything.
Yeah. All right, perfect. Yep, I'll say I'm on the same boat. I wanna know what's going on. I want to be able to catch it early, which is the third point in there. And if there is it, anybody else want to share their views?
For me, I think, yeah, the peace of mind is the like, so I'm good. Okay.
Yeah.
Like that'll just feel good. Sure. Okay. That's good. Good. But then there's also the not to be tested because I'm gonna sit there and worry about the results, right? So I hope what is the time frame of when you get tested and finding out the results? Do you?
So typically it's the blood work. So usually you'd find out, you'd get your prob scores probably within 2 days. It's like a typical blood work on a PSA testing, depending on the provider. But, it might take a couple days for a provider to get to you and let you know what the result is. Um, at
It'll
that time.
be a long couple
Hmm?
days, for me.
Yeah.
But it's yeah, the peace of mind would be great to have though.
Yep. And also, for some people, it's just, hey, the second option, which is my family will know and I'll know if I have prostate cancer or not. If you find it early, you could treat it early, and potentially save your life. And for some people, it's just having that risk factor. Plus, any other reason like that's that fill out. So this is kind of like a decision, balancing one. So you check off, 1 through 4 or 5, of why you would get tested. How about why you wouldn't get tested? Hey, are you going to worry about the test results more than you'd have peace of mind? Um, the other issue is that, like I said, prostate cancer, most often it does grow slowly. So you might find one that doesn't grow, or might not even cause you problems or decrease your life. Um, you got to worry about the treatment and the side effects. Um, and then, having a biopsy when you don't need one because, your test showed it was a little high, but then they ran the biopsy and guess what? You don't have cancer. You have to deal with those side effects or symptoms, such as issues with passing urine or problems with your bowels or problems having sex, potentially like after treatment. Um, so just to swing by into the next one, we'll go over like a couple of like the surveys we administer to both patients and providers, collecting like the quantitative data. Um, these surveys, for the provider, the main ones were satisfaction, difficulty in the communication that we assess like after every single patient encounter. And we basic demographics. It didn't take more than 5 minutes for the provider surveys. The patients, on the other hand, you're going to see had an extensive list of surveys that we conducted. Some of these surveys, they repeat throughout. We conducted surveys before their meeting with the coach and then after, as well as after their appointment with the doctor and 6 months later. Just to it looks like a lot, and some of these surveys still are only like 2 questions. In total, I think the post-appointment survey was the longest, and it took about 18 minutes. Whereas the post-coaching one took 8 minutes. And the pre one did take a little while, which was also about like 15 minutes to complete. But they've centered around like different factors, like the background factors such as demographics, literacy, numeracy, their medical history, or representation factors, which includes like knowledge or social influence, as well as trying to assess like program health system factors, such as like the access to resources, or services, and being able to have that communication conversation with their doctor. I'll go into a little bit more detail on like the actual, some of like the key measures after. Um, as Jerry asked in regards to the providers, we recruited 12 at the FQHC. As a caveat, this was about, or usually on top, about 6 or 7 at one time. It's just because of the turnover that we had to continue recruiting the new providers as they joined over these 4 years or so. And 67% of the providers were female, and also 67% were doctors. And in regards to the MD specialties, 63% were internal medicine or family medicine. So, patients. We had 558 different patients that are unique patients that were eligible to participate. Doesn't mean we were able to get a hold of all of them. Out of that, you'll see like there's over 1,000 patient appointments that we could have attempted to recruit them. So some of these patients are coming 2, 3, 4 times, and we're trying to get them. And we're able to get a hold of 370 of them. And this is where I give a lot of credit to the CHWs, because you know what? They're showing up to the clinic every day with a positive attitude, trying to recruit these patients. And if you look at it, 183 patients did not show up for their appointment, which is common in an FQHC because you know what? We're asking them to come an hour before their appointment. Some people, they're just coming between work, so they don't have that time, or something comes up, transportation issues, whatever reason. But the community health workers, they still show up, and they were still able to pull in 134 patients enrolled during the time. And we had 114 that completed everything on the appointment day, which was 3 out of the 4 surveys and the coaching session. And 100 completed it fully, which includes like the 6-month surveys. So I touched on it basically briefly about why people like after they enroll, they don't complete it. Like surveys take too long, time constraints, clinic issues such as insurance issues, or they can't fit them in, or language barriers. And then sometimes just simply they're just ineligible after enrollment, because we do the screening test with them and they say they can't do it, but then while we meet with them one-on-one or during the provider, they'd be like, oh, yeah, I had like blood in my urine last week or something like that. We have to make that update. So, some of the issues that we faced, I obviously discussed the no-shows, the COVID-19 measures. 6 months into our project, COVID-19 hit. So we had to pause for almost 4 months, restart it up again, and work on with the COVID restrictions during that time. Patients are sometimes difficult to follow up with, or their late arrivals and the provider turnover, implementing different approaches because you have to adapt throughout. Like some of the patients, they prefer speaking in person beforehand. So we started meeting in person in the clinic prior to their appointments to get them at their follow-up appointment. So we have to make some switches. And in regards to results, I will say that we were very lucky, not to say lucky, but we were very effective, and lucky that we were able to get the number that we did have. Um, as you can see, the prostate cancer knowledge like increased from 5.6 in control to 8. This is out of a 12 question survey that we piloted. And it was a significant increase. The average, like the median, was 8 compared to 6 in the control group. So just the median alone was higher, as well as just the mean over here. Another important result that we had is how interested were they in having a decision, or in participating in a decision about screening. And it was a significant increase in regards, based on a survey, from 4.6 to 4.89 out of 5. And then decisional conflict. How conflicted were they with their screening decision? We were able to decrease that significantly from 22 to 17. And then, did they make an informed choice? Over 65% made a more informed choice by meeting with the CHW prior to their appointment. When we say an informed choice, it's they had good knowledge and they had positive attitudes on a measure informed choice test and undergo the test, or they had good knowledge but had negative attitudes about the test, and they didn't undergo it. So 65% of them compared to 43% in the control. And the long story short, the CHW decision coaching intervention is an effective model for shared decision making to improve the quality of care for PSA screening and potentially other preventive services among vulnerable populations. And that's our ultimate goal, is to be able to incorporate the CHWs in the healthcare setting for not just PSA screening, but hey, bring them in for hypertension, other preventive care diseases that we'll have, or that we deal with on the primary care setting. And also, just to share a couple links, all of our information and documents that we have, they're shared in the CHW Resource Hub. I shared the first link directly to our program, which has the decision aid from the ACS, as well as other tools and instruments that we had that we actually incorporated the project, and the Community Health Worker Resource Hub, which is an initiative from the NYU CHW Research and Resource Center and the Community Service Plan. It has over 30 plus community health worker projects in there where to share information about, as well as tools ranging from cancer screening, not just prostate, but like breast, as well as hypertension, cholesterol, and in different communities, as well as the ACS's prostate cancer page for more information. So with that said, just want to say thank you to Mike, Rebecca, for letting me present. As well as you can see, we have an extensive team throughout the country as well. A lot in New York, but we also have co-investigators from Utah, Duke, Tuskegee, that were all participated in our study and supported our study throughout. So like I said, it takes a village to make, to keep things going and keep things smoothly, and to make health work for all of us. So thank you, and want to open it up to any questions that you guys might have. And sorry, I know it's cutting on close on time with everything. So
Fine. We'll do a quick thank you, Jerry, for everybody. Let's snap for his awesome information, and the way he presented it was awesome. So thank you very much for being with us. Please, anybody have a comment, a question that comes from the topics that were shared today before we go?
yeah.
Gosh, I have so many questions, but great work. Thank you very much for sharing it with us. One of the things that because we're really looking at this in South Carolina, one of the things that we know is that there is a lot of confusion about colorectal and prostate. and that both of these lead to death, but both are very preventable and with early treatment. And I know this study was just really focused on that. Did y'all, a couple of things. One, did you have an opportunity if people wanted to have a colorectal screening, could they have that as well at the same time? That's one question. And then I'm just really curious, did you detect any cancers along the way? So those are my, yeah.
Okay. So first, in regards to colorectal cancer, so since we incorporated it actually into their primary care appointment, they would have that conversation with their doctor just like they would normally have, in regards to it. We just added our part of prostate cancer basically to the end of their appointment. Um, so all other factors will be remain the same, and essentially we were just a reminder that they need to discuss prostate cancer also to a lot of providers because they would do it right at the end of their appointment or discussion and be like, oh yeah, they're here. Let's I forgot we got to discuss it. And I'm sorry, could you repeat the second question in regards?
The second one was, did y'all diagnose any?
Yeah, so yes, we were able to see some, but we didn't treat those patients. Those are treated directly with the primary care appointment. We did follow up to see if they had follow-ups or if they had if they were referred to urologist. If that was the case, if they weren't referred, then we would ping their doctor to make sure that they had that as a safety. But yeah.
Great work.
Thank you very much. Anybody else, anything for the goodness of the group?
Well, I worked with our local oncology group here several years ago, and there was a push to get men to come in for their prostate exams. And just now, as we were going through all of this, I was wondering, a lot of times women will try to express to men just how uncomfortable it is to go in and get a breast screening. And as uncomfortable as that is for women, I'm surprised that they don't have a promotion that says, okay, if your wife is going to go in for a breast exam, you ought to go in for a prostate exam. Do it as a couple, get it on the same day, and then you can both go through the discomfort and commiserate afterwards, and just make it a normal thing. If I'm going to go for have my breast exam, then you ought to go get your prostate done at the same time.
Yep.
Good thinking right there.
Yeah, that's definitely a good thought. I will say that was part of like our values clarification because some guys they didn't want to make that decision in regards to screening, but they'll defer that one to like their wife or their girlfriend instead. And if they said, "Hey, let's do it," let's do it. So it's important to have that conversation on both sides and to incorporate family members as needed if the patient prefers. So.
Thank you so much, Jerry. We appreciate everybody your time. Thanks for being here. Please come next month. We got some really exciting speakers coming up. We got Monty Robertson and others, but there's still spaces to fill. So hit us up. Check out our Facebook. Go to YouTube, and we'll see you next time. Thank you so much.
All right. Thank you, Mike. Thank you, Rebecca, again. So-
Jerry.